Raghav Preetham.
Good afternoon, everyone. I would like to thank AIOS for giving me this opportunity. I'm Dr. Raghav Preetham from Sushila Netralaya, Karnool, Nellore. I would be trying to speak about all about IOLs. I think it will take 7 hours, but I only have 7 minutes. So I'll try to concise the topic and give the. Oh, okay. Someone else is speaking now. I have the right. Dr. Raghav Preetham from Sushila Netralaya. I have no financial disclosure. To begin with, first I would like to thank Dr. Harold Ridley for his major invention of IOL. And also the second thing we'll all have to be thankful for him is because he never patented the technology. He never patented the technology. We have 3000 lenses in the market which are able to use and abolish blindness. Moving ahead, I have two real life scenarios. We'll try to understand what type of IOL we are going to use. One is a 50-year-old gentleman who's a software employee. He's a traveler and a hiker as well. He has a normal eye examination and P4 cataract, no systemic disease, and K readings are 44 both eyes. And the other side is a patient is a 65-year-old gentleman who's a farmer with few nebula scars and NO4 cataract. He's a diabetic since 2 years and this is the IOL readings. So will the choice of oil be same for both of them? What will be the criteria you will use and how do we choose them? To answer this question, we'll have to take into three major considerations. One is IOL considerations, patient selection and surgeon factors. We'll only be dealing with IOL considerations. So IOL considerations, basically the material, most commonly used PMMA for rigid lenses and acrylic. Silicone lenses are very fragile and very thick, so the importance of them has lost. And hydrogel lenses have a greater water retaining capacity but have high propensity to cause PCO formation. The same thing was proved in ACRS Leeming survey and ESCRS survey. Acrylic also has the opportunity to incorporate a chromophore into the material. We have UV blocking as well as blue blocking technologies incorporated. Some of these are the yellow lenses we use. And they come in three forms: hydrophilic, hydrophobic and rollable forms. Hydrophobic forms have greater contact angle greater than 70%, which helps them prevent PCO formation. And also the chromophores helps in reduced impact on glare, improved driving and improves photo stress recovery. These are the various designs we have in the market. To start with the ACIOLs, then we have the iris claw lenses, and the multiflex variant of the ACIOL helped and is still in use, and the artesian variant of iris claw we use for our secondary IOLs. And then we have a lot of foldable IOLs including the multifocals and the accommodative IOLs. So basic design has a optic and two haptics. It can be single piece or multi-piece, and the optic edge we'll be talking a little later. So the edge profile, when it is more square edged, it sits very well on the capsule and the chance of PCO is much less. Apart from the edge profile, the location of haptic over the optic, whether it is more anterior or posterior, will also determine the PCO formation. The more anterior the location of haptic is, the chance of PCO formation is less. And the haptic design, the new Technis 2 have come up with frosted haptics which sits very firmly into the bag, helps us in our toric lenses. The same thing with IQ, which has stable force haptics, whereas the Hoya lenses have a textured rough haptic surface which helps in rotational stability. One word about spherical aberrations. These are the high order aberrations which have caused some visual troubles of late. Using an aspheric lens, we can focus both the peripheral rays and central rays onto the fovea, giving a crisp vision, improved contrast sensitivity in mesopic conditions, and decreased total high order aberrations. How do we choose the lens? We have three lenses in the market. One is Technis, Acrysoft IQ and Softport AO. So which in cases with corneal irregularities, it's not a good idea to put an aspheric lens, or whether it's better to choose a zero order spherical aberration lens. Toric IOLs, there's a talk next to me, so I'll just skip this part. And then we have a concept called as enhanced monofocal, which are the pseudo EDOF lenses. One is the Technis iHance lens, which works on the refractive technology and continuous high order aspheric surface. As you can see, there is hardly any difference between the Technis Eyehance and Technis One Piece. Clarion uses the residual spherical aberrations to improve the depth of focus, giving us the enhanced monofocal effect. Refractive multifocal lenses are out of practice. Diffractive lenses are still in practice. However, the intermediate vision is not as good as we have seen. So we are now in an era of enlightened optical technology, of the quadrifocal technology of the panoptics, where instead of one gradation, they have 3 gradations, and whatever the stretch, as you can see here, it helps us for enhanced contrast for the distant vision. So one word about the EDOF lenses is the wavefront shaping technology of the VVT, which we have, helps us improving the intermediate vision as well. I'm running short of time, so I hope I helped you choose the lenses for both the patients. My choice for the first case would be an Acris of VVT, and for the second case would be a non-aspheric lens like a single piece or a Technis sensor lens. Thank you.
You're talking about 3 different types of aberration, 3 lenses, aberration-corrected lenses.
Yeah. Yes, sir.
I thought finally you will talk about that for these situations.
So the Acris of VVT, as it is, comes with an aspheric surface. So it does prevent the high order aberration. In the sense, it does prevent the spherical aberrations. And the second IOL, why I chose an non-aspheric lens is because the patient had a couple of opacities in the cornea. That's the reason I put both the cases. Right. Thank you.
The next speaker would be Indrajit Kothari. He'll be talking to us about toric IOLs.
Good evening, everyone. This topic was actually discussed yesterday itself. How many attended yesterday's presentation? Do you have the presentation there, Indrajit? So I'll. Oh. Is it EDF or torics? EDF. I have 2 presentations actually.
No, it's toric IOLs.
Yeah, one more presentation. So, by the end of this presentation, I would expect all those who are present here to at least do some astigmatism reduction for all their cases. Okay. So, not all patients need toric IOLs. Not all astigmatisms need to be corrected with the toric IOL. We can also reduce with incisions. Up to 0.5 against the rule can be reduced with a simple up to 3 to 3 mm incisions. Whereas with OCCA, that is clear corneal, opposite clear corneal incisions, we can reduce up to 1 diopter of astigmatism. So always any premium IOL, not only toric, when you are going for any premium IOL, always rule out pterygiums, OSDs, corneal ectasias, and also do a topography whenever needed. Accurate biometry, optical one is always preferred for all these patients. Precise A constant should be used. If needed, you can also go for online formulas. Precise keratometry. For spherical correction, always use the optical biometer. But for axis and the corneal diopters, use either keratometry, topography, or even image guided systems. Or optical biometers also okay. Always take your PCA, that is a posterior corneal astigmatism, into consideration, and also your SIS, surgical induced astigmatism, into consideration. And always see that the patient will have a good vision before you are going for any premium IOLs. Always under promise and over deliver. So what the patient wants is also very important. The patient might want to go for without glasses. You can always go for a trifocal torics if it's suitable, or else you can go for EDOF if needed. And based upon the condition, but sometimes the patient might have some retinal pathologies. We might not go for a multifocal. We can mix and match also. Maintaining toric IOLs is very difficult, so we have to order them in advance. and depending on the various available lenses and options and what the patient wants, we have to order them. Keep always the stock ready for 3-piece and AC IOLs as a standby. The spherical equivalents, power as I told, we can also use immersion. Suppose it's a mature cataract, there is no other option. But I think whenever it is done, it's better to go for an EDF torics because they have more tolerability. And suppose you have to convert, always keep a lower cylinder lens ready with you. One next tip is that reference marking. That's very important for any toric IOL. So we can use a bubble marker or direct freehand toric marking with a marker. Always see that the patient head is straight. There is no tilt of the face, tilt is not there. The patient keeps on seeing the eye should be looking straight. Then go nearer, and if needed, always use a speculum if the patient is not cooperating. But if you use a speculum, always remove the speculum and reassess your markings, because sometimes the patient will be squeezing their eyes and there might be some amount of torsions. Nasal marking freehand will be difficult, so you have to be a little bit careful. If you are ambidextric, it's even better. Next step, important step is toric alignment. So once the surgery is over, you place in IOL. Beginners, I would advise you to place under visco. We are usually placing under saline, but initially it's always better to place under visco. Rotate the lens into the position just 5 degrees away from the intended axis, clockwise 5 degrees away from the intended axis. That is because the lenses tend to rotate clockwise, so we have to keep it anti-clockwise 5 degrees away from the intended axis. So the lower one, you can see there is a little bit difficulty in rotating the lens, the haptic into the bag. In such cases, it's better to use visco to rotate into the bag, dial into the bag. In small pupils, it will be difficult, and also ascertaining the position of the lens will be difficult. So we may have to retract the pupillary margin and assess. For such small pupils, maybe it's better to go for a toric EDFs, which have better tolerability. So when do you do redial? Suppose we already placed the lens, they had problems like, or else the pupil was small, we couldn't assess properly. When do we redial? Most of the rotations occur in the first 1 hour. So we usually do under topical anesthesia, reassess the patient within half an hour to 1 hour and see. Suppose there is any significant rotation, we redial on that day itself. Suppose that is not significant, or else we feel it might become better, we wait for 1 week to 3 weeks, and depending on the calculations, we redial the patient. We use this astigmatismfix.com website to assess the amount of redialing to be done. But after 1 month to 6 months, maybe better to consider LRI or OCCIs or even PRK. So most concerns will be whether toric options are available for all types of IOLs. The newer generation EDF, some EDF companies have not yet come with the toric options, but they will be coming in the future. This technology, the people will be asking, it's very expensive, is it worthwhile? Any technology, newer technologies, they are expensive, but compared to the effectiveness of those technology, they are all reasonable expensive. Will the results last lifetime? For torics, we cannot give the guarantee because we have to be aware that all eyes, this astigmatism changes with age, especially against the rule astigmatism keeps on increasing with age. So we tend to overcorrect all against the rule astigmatisms and undercorrect with the rule astigmatisms. So that after maybe 6 months, after 1 year also, the lens will be suitable for that patient. Yes, they can be used for presbyopia and clear lens, but it's always better, especially initially it's better to go for only the hyperopic patients who are having very difficulty with their glasses. I would not prefer to do in young patients on clear lenses. Cataracts, definitely yes. Should we wait for upgrades? Some lenses are coming with better materials, which have lesser vacuoles, lesser glistenings. Maybe such lenses we can wait, or else the technology is pretty good. We can go for any toric lenses whenever needed. Thank you very much.
Any questions?
I have a question.
No, on the day of on same surgery. Like if there is any residual astigmatism, yes, there are some patients where we had residual astigmatism. Around up to with OCCI we can correct up to 0.75 diopters on the table. So we have to take the patient again to surgery if needed for redialing. On the table we can do. Suppose like one patient we might have seen, I done OCCI while I put an toric lens, because we ordered a lens, but on the day when we calculated cylinder was coming more, we had to go for a 3 diopter lens, but we had a 2.5 diopter lens. So that extra 0.5 we reduced with OCCI.
So one more point is, other than the www.astigmatismfix.com, you can also use the Barrett RX calculator.
Yes.
And you mentioned in the treatment of presbyopia with clear lens, you will not use toric options.
No, not now. We would like to be cautious about that, especially
Yes,
for 066 vision. Only
but you need to use, if it has a corneal astigmatism, then if you don't treat, and for presbyopia correcting, if you are planning treating presbyopia but not treating astigmatism, then it will not.
Not that. I wouldn't like to go for any cataract operation in such patients. That's what I meant.
No, that's okay.
Yeah. I would like to be cautious of operating any clear lens presbyopia patients.
What's your opinion about the hydrophilic lenses with toric?
We have used very few hydrophilic lenses. Some lenses are very good, but most of them like a single piece, yeah, you can want to say anything?
A-group lenses which come with custom toric have very stable haptics. And hydrophilic lens, is it really well? Sometimes if you miss have easier as well, is it really comfortably well in the surgery?
The design of haptic is having a big role on.
Yes. Plate haptics in some cases might be better, but all these lenses like which are C-loop, it's better to go for this frosted lenses designed with haptics with frosted surface, or those with ridges. Their rotational stability will be good.
The disadvantage with hydrophilic lenses again is what he was talking about, rotation. Rotation is best because hydrophobic lenses are tacky, and of course along with the beautiful videos.
Thank you.
Something you forgot to mention that before you align these lenses, what do you look for? It was there on your video. 40 day
Yes. Yeah, that. Thank you very much. One more point I would like to say that someone was asking like, I have a video. Why would I like to use a phone?
Because this is for the lower people who can't afford the thing.
Yeah, one more thing is even with every patient, sometimes
Next topic would be toric IOLs, what went wrong by sorry. My experience with toric IOLs, Dr. Patni. Sorry for that mistake. This is Dr. Patni here. Okay, Shalini. Toric IOLs, what went wrong?
Thank you so much, Dr. Elaine. Good afternoon, Chair and delegates. I'm going to talk about toric trouble, my toric went wrong. So I don't have any financial interest, so we can correct astigmatism by a variety of toric IOLs already available. Now this is a case of a 63-year-old male patient whose right eye was planned for surgery, and we can see that the keratometry readings, they showed a cylindrical error of 1.76 at the degree of 84. So this was preoperative data which was fed in to get a toric IOL, where axis was marked at 180 degrees and incision location was 150 degree. So this is the thing, and when in post-operative period, if we see the markings, now this was the 180 degree and this was the marking on the IOL. So there was a rotation in the post-operative period. Another case, this was another patient in whom the toric IOL was planned at 83 degree, but when we saw in post-operative period, there was a rotation and there was a refraction, residual refraction of 0.5 and cylinder at 90 degree. So this is the most common problem which we face in post-operative period, where we have rotation of these toric IOLs. So just we were discussing, we can find out by these websites that how much rotation we should do again to align the lens in the post-operative period. So these are the toric results analyzer. So important consideration is there any rotation or how much rotation is there and how much we need to rotate again. So how to measure was already shown by a wonderful video by Dr. Indrajit, so I will skip. Now I also found this iToric app very useful to assess that how much alignment we have to do. So it is a simple app, you can download it on your mobile phone, and then once you click a photograph of anterior segment photograph and then align it with the markers on your mobile phone, and once you have aligned it, you enlarge it and check that what is actually the axis where the lens has been put. So here you put the axis of placement, so it is, if it is 40 degree, new axis of placement it will give you like this, so it is 40 degree. Now this, by this aligning this mobile on the picture, you can check that what is exactly the axis of our IOL which has been placed inside the eye. The best part about this app is that it is there is a gravitational fed in, so even if you rotate your mobile, still the axis markings don't change. So we did a toric results analyzer for this particular patient, and it showed us that we need to rotate the lens by 10 degrees. So we again did it the rotation under hydroimplantation. So I think hydroimplantation has already been discussed by Dr. Kothari. So it is a good idea to rotate it under hydro because you don't need to remove the viscoelastic. Otherwise you need to go underneath the IOL and remove the viscoelastic. So after 1 week, we can see the alignment was exactly at 40 degrees. So the golden rules about rotational stability, we should be very meticulous about wound construction. There should be well-centered capsulotomy. The position, whenever you are putting the IOL, the capsule should be absolutely clean. There should not be any fibers. It is always better to use cohesive OVDs, and a final alignment, if you are using viscoelastic, should be done after complete removal of viscoelastic. Seal the wound, hydrate the wound nicely. Neither overfill or don't underfill, and then bring the eye to the physiologic pressures. Now this is another case which we did in our patient. This was case number 4, and the IOL axis was to be put was 174 degrees, but when we noticed there was a residual astigmatism of 0.75 diopters at 80 degree, and vision was 612 in post-operative period. So again we went back and we checked our data that what mistake we have done. So we checked that axis of placement was perfectly all right, keratometric readings were all right, and the incision location was at 180 degrees. So what was left actually? We saw that the surgically induced astigmatism which was fed was 0.55. So we just give it a thought that this SIA was calculated way back when I started my toric IOLs. So again we collected our data, and again we collected the SIA, and what we found was that now it has reduced much lesser, and for right eye it was 0.16 and for left eye it was 0.3. So I just wanted to emphasize that if you have calculated it a very long back while you have started your surgery, and now after say 5 years, 10 years, again recalculate your SIA, and for right eye calculated separately and for left eye calculated separately, and then when you feed in the data, then we found that the IOL was of SN 685 should have been put, which was T4 we actually put. So that lesson learned is that we need to keep updating our data regarding SIA. So you can feed in the data on drhill.com by pre and post-operative keratometric reading, IL power, post-operative fraction, and for right and left eye. It is important to choose one type of lens. Don't mix the lenses and then calculate. Just choose one type of lens and then calculate for that particular lens. So now coming to another case where uneventful phaco with toric IOL implantation was done. Anterior segment was satisfactory, but then uncorrected visual acuity was just 3/60, and vision with pinhole was improving to only 5/60. Again we analyzed that what was the problem, why vision did not improve. So we rechecked the IOL power, and it was normal, but but refraction was +4 diopters of spherical with -9 diopters of cylinder. at 89 degrees. So we understand that whenever there is rotation, with 10 degrees of rotation, the loss is 1/3. And if the astigmatism has doubled, that means there is 90 degrees of rotation. So we dilated the patient and we rechecked that what was the issue. So 80 degrees was the axis on which the IOL was to be put, and we checked that yes, it is at 80 degrees. Again, we were surprised that if there was no rotation, why the astigmatism was doubled. So when we again retrospectively analyzed the data, what we realized that the data which was fed in the chart, in which the axis was exactly changed, like at 0 degree was put at 180 degree, and 180 degrees readings were put at 0 degree. So when we rotated it exactly at 180 degree, we found that, shall I finish this case? Okay, thank you. Fine. So we rotated it at 190 degree and we found that vision has improved to 6/9. So lesson learned is that don't rely on anyone. Don't rely on your staff or maybe or the person who is calculating the data from IOL team. Verify it yourself, and then so that you don't have any residual refractive error. So this is the last slide I would like to see. This was a bubble marker, and once you see, if you put it along the line and see how the markings are there, one is falling on the horizontal line and another one is falling above it. So sometimes even the instruments by which you are marking might not be correct. Always check it yourself and then only mark. So now I will come to conclusion. So to conclude, I will say that toric IOLs are very rewarding IOLs. Patients are extremely happy if it is done correctly, but it should have accurate measurements, accurate power calculation, accurate marking, and accurate positioning. Thank you so much.
Excellent presentation, ma'am. So basically, to summarize, to get the best results, we have to minimize all the variables. So biometry should be perfect, perfect marking, and perfect alignment. And sorry? It goes without saying.
So we
perfect
all have
surgery.
perfect surgeon assuming that.
So very nice. And
Thank you.
just one aspect of you mentioned about the customized toric IOLs by Care Group. It has excellent results. But one thing we need to remember is you should never implant it upside down. If you implant it upside down, it gives haywire results. So that is something, because it's a plate haptic. Sometimes we get confused how to put it.
Right, right.
Okay. Your phone is ringing.
Yeah, smart.
It's always 0, 180 only.
Yeah, you can simply implant it, the smart toric IOLs.
Because of the design, because of the elastic technology, we need not have to align the
Yeah.
One question for both of you, speaking about toric IOLs. You said it can, if there is a rotational problem, now you have to decide whether to correct it or not. In certain cases, you cannot be Veradal and whatever the astigmatism is, whatever you said. But when just by looking at the refraction, can you say whether it's correctable or not?
Just by looking at the refraction. Now, if there is residual refraction and if there is no spherical error, that means it is residual astigmatism due to miscalculation. And if there is hypermetropic error is there, that means it is correctable.
The spherical equivalent should be 0.
Yeah,
that
spherical.
case which you showed, na, plus
Right.
4.5 minus 9, means
Yeah,
it has
exactly.
flipped 90 degrees
So,
classically.
so if there is a spherical equivalent is there, that means it is correctable. If it is 0, that means it is the residual astigmatism because
Ulta. If the spherical equivalent is 0, that is if it is a cross cylinder,
Yeah.
plus 4 minus 8,
yeah,
you had minus 9, very good.
yes. So
Then
it
is correctable.
yeah, it is correctable, right, right.
And it is
Otherwise,
flipped 90 degrees.
yeah,
Typically.
So that it helps a little.
like the second case which I showed, in which there was spherical error was 0, but there was residual astigmatism. So that means
That means it is rotated. And one more thing is, you always look at the wound. Many times your wound may have wound burns. So
Right.
look at the pre-op K and post-op K first
Yeah,
thing.
yeah.
So if you have had induced astigmatism with your wound, then there is no point doing all this. That is the first thing you should see on slit lamp. Okay,
Right.
let's move on to the next.
Yeah, thank you so much.
Field of lenses, my experience
I'll just start with the slides. So these EDOF, ERV, advanced monofocals or pseudo EDOFs, all are being interchangeably used. Main thing is purpose of all these lenses is to give better intermediate vision. So it creates a single elongated focal line and enhances the depth of focus, or the depth of focus is in the eye, whereas the depth of field is for the patient. Main purpose is to reduce the phenomenon, all those photopic phenomenon, glare, halos with multifocal IOLs. Initially when we started using multifocals, we used to have like face lot of chair time wastage. We used to spend so much time with the patients. Once we started using EDOFs, all that has come down. We are very happy with EDOFs as compared to multifocals nowadays. So this is like, it should be not be inferior to the monofocal group for distance vision. So all these are like, so this is the range of the vision which we get with monofocal. One thing we have to always counsel the patient is that they won't have very good near vision. They will need reading glasses. Once you say they will need reading glasses, you are left alone, or else they will keep bothering you. Always tell them that they will need glasses for any EDOFs. Oh, sorry. This has to be enlarged. So, so these are some EDOFs which we are injecting under saline only. So the limitations is one thing, these EDOFs don't have toric options as of now. So we do correction with like OCC as I mentioned. And there is a learning curve for all newer EDOFs. So either the loading or else implantation. This video, the lower left side, you got a pointer here. So once they inject, yeah, it's okay. So you can see that it got stuck. So they had to like push it or pull it out with force. Luckily there was no breakage, but sometimes that also might happen. Again, choosing the right IOL and power, all these things we already discussed. So this is one more video. So here the first one, the upper top right left is we are injecting using visco because that was a preloaded lens. For preloaded lens you need to use both hands. So we are the same video, it is a repeat. So there is a difficulty in dialing into the bag. Depending on the different lens manufacturers, you have different marks also for toric lenses, also for the EDOF torics. But main thing is EDOF torics, the tolerability is much better than normal monofocal torics. So even if there is a little bit this way or that way, rotation or no need to redial sometimes. So all these things we already mentioned. Thank you very much. Actually, like this, they got interchanged, I think, some videos. Thank you.
Okay, you said EDOFs torics are not available.
Some companies, some manufacturers.
Yeah, some,
yeah,
but you have a lot of EDOFs.
Yeah, lot
where
of EDOFs
torics
with toric
available
options
also.
are there.
So basically what we need to know is if you compare it with trifocals, then today's day in those patients who regularly do night driving or those patients where you would have avoided using trifocals, you can use EDOFs.
Yeah, we have done mix and match. Suppose there were some patients initially who went multifocals and trifocals who are not happy, either due to they have been having diabetic retinopathy changes as of now. So the other eye we went for a EDOF lenses instead of a trifocal lenses.
Diabetic retinopathy with maxilla involved?
No, early changes.
No, you said glasses you always prescribe for the EDOF patient.
No, we advise, we always counsel the patient that they might be needing glasses. They will need to wear glasses for reading.
Any correction you make in your IOL power?
A mix and match we do sometimes, but still we advise, counsel the patients like that. So we always, even if I have a stamp, you will need glasses after surgery. So just to not to like, so that we don't, even if you have some, like there initially when the IHANS came, it was like marketed as intermediate vision. Patients used to ask us, I can't even see my mobiles.
So
Do you?
if you're not dominant, you create an offset.
Yes.
Normally by 0.75 minus.
Yes, bilaterally they will be seeing better. That we do that,
So
but
you
still
choose
there will always be some
emmetropic power.
surprises.
You choose emmetropic power in all your patients?
No, usually we go for a little bit myopic in the first eye. The second eye will correct accordingly.
I have a doubt. So, EDOF lenses, they are based on the spherical aberration. So, in case if you leave them more myopic, you are inducing more low-order aberration. So, the overall quality of visual experience will be lower. So, from what I have read, at least, the EDOF lenses work much better if they are closer to zero or
Yes.
little more high.
That's the reason we don't give an offset of more than 1. So with what he was talking, non-ring lead off, ideally you have to give an offset of 1.25 or 1.5 actually, because the non-ring lead off, what he was talking about, I have one of those things. You need 1.5 offset, but we don't do that. We do 0.75 and wonderfully works.
We usually go for only 0.5. One more thing is, as I was mentioning, all EDOFs, they have intermediate, sometimes in the intermediate range in the central zone. So suppose it's a pinpoint pupil, we have to always see that it's hyperopic rather than going for myopia.
Thank you. We would like to now invite Dr. Mohit Khatri. He would be speaking on the wrong choice of IOL in an unexpected mess.
Good afternoon, everyone, and I'm very much thankful to AIOC and all the my chair and vibrant colleagues. And this AIOC, I definitely chose this topic for a very specific reason. In 7 minutes, what can I say? And I'm really happy to see some young guns here who will be starting off with their practice and making some good decisions. So I'll be keeping it very, very simple and very, very basic. No hi-fi things. Please take some carry-home points from here. I'll just give some of my mistakes, some cases which went wrong for me. Recently, I had a patient, young male with retinitis pigmentosa and an early cataract, and a simple guy, not asking for much things. So a basic phacoemulsification was done and a hydrophilic IOL was put in the bag. What happened after 4 years, the patient came without any trauma, and this was the picture. That whole of the bag came in the AC with the IOL in the bag. So what went wrong? We just thought, what exactly happened that in these scenarios, sometimes there is a progressive zonulopathy which leads to this capsular phimosis, and there is unopposed capsular bag fibrosis going on. Finally, what it leads to is a late subluxation of the bag, and then these kind of pictures can be there. So this was simple to deal with, nothing rocket science. The whole thing had to be taken out. You just enlarged the incision, the whole thing was taken out, and then the patient was given an AC IOL. So a simple case, patient had retinitis pigmentosa, and that gave a lesson. So one case is enough to teach a lesson. So you see the whole of the bag will be displayed. This is your bag, the IOL is taken out, and then we did a vitrectomy and then gave a AC IOL, leave that. So what lesson was learned, that whenever you deal with patients like these, try to prefer a 3-piece IOL and just avoid hydrophilic single piece IOL, so that you can resist the capsular contraction better and the lens stays central for a longer period of time. Then again, as you find a higher astigmatism, first thing, can I do a toric? I want to get a toric done. So is this my first toric? Yes. So a K1 of 46, K2 51, a toric IOL was designed and toric was done. Experts are there to teach you for hours what can go wrong, but then you never know, you are dealing with keratoconus, and then it wasn't a centralized thing, and the whole thing was on the slope. So the visual axis, if it is decentered and if there is an irregular astigmatism, toric IOL is not the choice. So not every astigmatism is to be dealt with toric IOL. So whenever you see your IOL master, see this SD, standard deviation. Your these SD readings should not be more than 0.2 or 0.03 millimeters, and if it is like that, then it is highly suggestive of something wrong. You might be dealing with an irregular astigmatism, and then go for topography, see what's going wrong, and then decide for the IOL. An old uncle comes, he's rich, he says, I am a Google user, are there premium lenses? I don't want to use glasses. You say, yes, I'll give you a trifocal. Same thing was done by me, 75, 80-year-old male, mature cataract, heroic surgeon, did a good phaco, and then ignoring the small miotic people, gave a trifocal. Now he was not able to read. Uncle again came to me every evening, I am not able to read. Okay. So again a lesson learnt. The diffractive IOLs, whenever you have rings, anything, please see your patient undilated also. If it's a very small pupil, no need to jump for a trifocal or a IOL with rings. These IOLs are pupil dependent, and in these, when it will be dilated, you will be proud of yourself, and when you see the patient undilated, I don't want to say something. Next case, if there is PCR, I have taken a sum of money and I am committed to put a lens. This should not be the feeling in the OT. Have your plan be discussed with the patient, have your plan be prepared in the OT. So if you have planned the same IOL and you try to put in the sulcus, then you start getting these kind of pictures. This is the patient I saw last week. These are the toric marks. So this IOL was put in sulcus, and with due respect to all the manufacturers, no manufacturer gives you a claim that my lens will be there in the sulcus wherever you put in. So please don't take this message home that this very lens is going to stay in the sulcus with the toricity intact. No, it will not. So IOL decentration will be there, sunset appearance, unhappy patient, all that will be there if you don't manage these scenario perfectly and don't be committed to a particular lens. This patient had a multifocal, see the dangling cortex, it's in sulcus, the IOL is decentered, now it's a mess, how to tackle it? See here, IOL again going this way, vitreous coming here, this is the way to go about. The third picture, do a very thorough anterior vitrectomy, prefer a 3-piece IOL, and then always try for an optic capture in order to have a central optics for your patient and a good quality of vision after a PCR has occurred. A myope, -2, -2.5, such kind of people easily come, working in a bank, maybe a teacher, and then they want a cataract surgery done. You did a great multifocal IOL, patient was 6'6", but then he was pathetic, he's miserable. He said, I never used glasses for reading, what have you done, man? Now I can't just read anything. Earlier I was using glasses for distance, but I used to read my newspaper. Now what have you done? So only thing what you lacked here was counseling. You have to learn this, that you need to customize your lens for your patient, seek option for presbyopia correction IOLs, and as the expert said, EDOFs may be a good choice, maybe a trifocal with due respect to toricity. Again, if you omit toricity and put in a premium IOL, it won't work. So customize your choice of lens. This is a tricky affair. I think one meal is required to explain you all that, but then you can have an unhappy multifocal patient after 6 vision if you do not do a proper workup beforehand. A small point is here, angle alpha. So we can have, see my time is up, but we should read what it is. Actually there are axes, the visual axis, pupillary axis and the optical axis, and in between these axes are the angle kappa and alpha. So if you have eye trace kind of equipments, they give you easily how to measure it, but this is the picture I want you to learn, that whenever you do an IOL master, see these things, Px and Py. These are the x and y coordinates of the pupillary axis. You just have to add it, and then what you get is called chord, C-H-O-R-D, chord. So this chord actually tells you if the magnitude is more than 0.6, this patient is not fit. This is an indirect measure of angle alpha, angle kappa. I will explain you, I can explain you later on because my time is up, 7 minutes was not enough for that. But then this is the factor, whenever you have an optical biometry done, please see these readings. X and Y, no signs required, just add them. normal value is 0.3, but if it is more than 0.6, this is not the choice for you for a diffractive or a ringed IOL. And pictures speak, don't commit this sin ever. Something is hiding, you all can see. Okay, thank you.
That was a very good compilation of cases.
My mistakes.
Nice. Only one, the first one, what you said, that retracement of some, not only capsular contracture, we know that this is progressive weakening of solids. So that was a good point. 3-piece IOL and if possible, CTS.
Yeah. So we'd like to call the next.
So next I would like to call Dr. Harika Reddy for exploring IOL exchange series.
Can you please check the mic? Excuse me, mic.
Good afternoon. Today I will be talking about 3 case scenarios of where I did an IOL exchange. Cataract surgery is no longer a therapeutic procedure as it was done in the 80s. Now it has become more of a refractive procedure. I'm just going to skip to the case scenario. So 67-year-old female came to us with a complaint of diminution of vision in the right eye since 3 months. She had already made up her mind that she had poor vision in the left eye since 10 years. She's given a past history of undergoing cataract surgery in the left eye at a camp 10 years ago. So we went ahead and she had a myopic fundus, so we did with optical biometry it came up to be +8, so we did a phaco and implanted +8 IOL. She was happy with her right eye vision, so she wanted some visual improvement in the left eye. With -12, she was able to read about 612, and optical biometry showed about +4. So this is a video I have. Since it was an SICS and it was done about 10 years ago, I made a corneal tunnel about 2.22 mm. Since it's a rigid IOL, I injected a cohesive to make sure the haptics are dialed into the AC gently. And I extended the tunnel to about 3 mm to ensure easy explantation of the IOL. And +4 lens was injected into the bag. And I closed the tunnel with infinity suture. So out of curiosity, I wanted to find out the power of the rigid IOL, which was about +21, which is why she was not able to read. So this is the post-cataract refractive surprise. The second case is a calcified IOL. These days, we're not getting these, but before we used to use hydrophilic lenses. It was quite common. She had undergone a phaco about 5 years ago, and she had gradual vision loss in the left eye since 14 months. She had right eye she was reading 6.6, and in the left eye she was reading only hand movements. Since it was a calcified IOL, we did a B scan, it was normal. And in the optical biometry pseudophakic mode, I calculated the power and explanted the calcified hydrophilic lens and implanted the aspheric hydrophobic lens. This is the third case. He's a 52-year-old male goldsmith, so he obviously had high visual demand. In the left eye, he had undergone cataract surgery 5 years ago, but in the right, he actually came to us with complaints of diminution of vision in the right eye, and he didn't want to depend on glasses to work on for his work. So he wanted a multifocal IOL, went ahead and did an uneventful phaco with a multifocal lens. And he wanted this, he was seeing well in the left eye, but not as well as he wanted, so he wanted the same visual quality in the left eye too. we did try explaining him to use the right eye for his near vision, although he wanted the same visual quality in the left eye as well. So I have the video. So this was an aspheric, good quality, probably an IQ platform monofocal, and he did want to have a multifocal in this eye as well. So I use a twist technique to explant the IOL, which was popularized by Dr. Uday Devgan. So this was another patient of mine, so I just kept this video to explain the technique. The trailing haptic is brought outside, and using the McPherson, the optic is held at the optic haptic junction, and with the help of Sinsky, it is twisted and rolled out of the eye, and the lens is explanted in toto. And PanOptics was implanted as he wanted a multifocal IOL, and we had a very happy plano refractive Goldsmith in both the eyes. So the most common indications for PCIOL explantation are IOL dislocation, incorrect IOL power, that is the post-cataract refractive surprise, IOL opacification, persistent iritis, and UGH. As with any surgery, IOL exchange is also associated with its fair share of complications, the most common of which is PCR, which can also lead to vitreous loss. And if the IOL is sitting in the eye for a long time, when the lens is tugged on with force, it can lead to zonular dialysis, retinal tears, and even cystoid macular edema in the long run. So IOL exchange should only be done when the visual problems caused by the current IOL are cannot be managed by non-surgical means, and each case is unique, and the decision to perform IOL exchange should be tailored according to the individual patient needs and circumstances. Thank you.
Thank you. Do we have about a minute each of them, please? We started late. The previous is two more. After this, two more. Can we make it faster than that, please? As fast as possible. And please keep the timer. I don't see that.
Good evening. I'll be skipping to the videos as so. This is a case of phacoemulsification. It's a grade 1 to grade 2 nucleus. Right from the start of surgery, I was unable to create a trench due to the soft cataract. I made a crater, and I found that the nucleus wasn't rotating properly. So at some point of time there must have been a small rent, and I'm still trying to rotate the nucleus. Nothing is going as per plan. Please observe carefully. There you go. Momentary dilatation of the pupil with sudden appearance of red reflex, which says that we have created a rent successfully. At this point of time, what most people do is retract the phacoprobe and everything outside the eye, which creates negative pressure and prolapse of vitreous in the anterior chamber. We have to retain the phacoprobe inside the eye and put a dispersive OVD. Here what I tried differently is, since it's a grade 1 nucleus, I went ahead with a cutter. I used the side port that I've made for the infusion, and I've continued the surgery. The IOL, the rent did not expand. Since the rent did not expand, I finished the whole case with a cutter, and I've implanted the IOL away from the PCR in the back. If you have a good capsular support, if you have a good anterior capsular rim, but a bad PC, I mean a large PCR, you can go ahead and if put the IOL in the sulcus, a 3-piece IOL, and do an optic capture. But you have to, before doing that, make sure that there is no vitreous in the anterior chamber. You can use a triamcinolone acetonide to stain the vitreous and do a proper anterior vitrectomy, and you can place the IOL in the sulcus and do an optic capture for the IOL to be in a more physiological position. So basically any secondary IOL is an IOL that is placed not at the same time of cataract surgery but much later. It can happen due to pre-existing conditions or intraoperative complications. We have many secondary IOL implant options, most popular being SF IOLs and iris fixated IOLs. I think my Dr. Jaya Madhuri is speaking about iris fixated IOLs later, so I'll be skipping that part. You can have a very good result with an iris fixated IOL, which she'll be showing you shortly. Scleral fixated IOL, the most popular one is the Gabor technique, where or the handshake technique described by Mr. Amar Agarwal, where the lens, where the IOL is placed in a more physiological position behind the iris. Just implant it in the bag, inside the eye with the help of an intraocular forceps. Externalize the haptics on either side 180 degrees and just tuck them into the pre-made scleral pockets. A small modification to this is the Yaman's transconjunctival technique described by the Japanese ophthalmologist, where a 30 gauge needle is pushed under the iris and the haptics are tucked into the 30 gauge needle on either side. Both the haptics are externalized, and once they are externalized, cautery is applied to the tip so that there is slight deformity of the haptics, and these are then pushed towards the sclera. AC IOLs previously were thought as a bad option, and many people may have told you not to go ahead with AC IOLs. Yes, in the past there might have been a lot of complications because there were no PIs were not done properly, or vitrectomy was not done properly. If it works in your hands, you can have good results with AC IOLs too. I have seen many AC IOLs doing well for the past 25-30 years. So if it works in your hands, you can go ahead, do a good vitrectomy, do a good PI. So it is the take-home message is anticipate the complication, recognize the complication early, so that there is no, before you end up in more complications like a nucleus drop or something. Choose the right technique, the technique that works in your hands. Be honest with the patient. If he is immediately post-operatively, he may be fine, but he may land up in complication later. If don't hide, try to hide something. Talk to the patient if a complication has happened and how you have managed it, and under promise and over deliver. Thank you.
Thank you so much, Dr. Meher. Now I would like to invite Dr. Jaya Madhuri for a presentation on iris law lenses, video-based learning. Dr. Tanvi is here. Be ready, Dr. Tanvi.
A very good afternoon. Basically, there are many queries how to do an iris claw. So I'll be skipping few slides. So I just thought I will talk about my journey in iris claw IOLs. So what extra workup is needed? Basically nothing much. The routine cataract workup with my importance to the size of the pupil, and if any presence of any PI if present, then assessment of the sulcus is very important before proceeding with the iris claw, because sulcus IOLs are the time tested ones, and indirect ophthalmoscopy is a must to detect any peripheral retinal degenerations. If present, barrage them. The second query is a VR setup needed? There is no need for a VR setup. Routine anterior segment surgery with our phaco machines with a good anterior vitrectomy is what is enough. I again stress on this point. I always say doing an iris claw without a good anterior vitrectomy is a crime. Never do. Never go ahead with a claw IOL without doing vitrectomy. Now, what case should I select for a claw IOL? It's a simple answer. Any case of aphakia with a good iris tissue support with an absent sulcus. The pupil size, even in that case, about 5 to 6 mm pupil, even that iris is sufficient to place an iris claw IOL. The indications, I divided like a planned indications where you have subluxated lenses and subluxated IOLs, and for a aphakic rehabilitation we can do. And in unplanned conditions where you have a very large PC rent with no adequate sulcus, or a large zonular dialysis where we cannot place a bag or a sulcus IOLs. Now, what extra instruments do we need? You don't need much of an extra instrument. I usually use a Shepherd's forceps for a better stability. If you don't have a Shepherd forceps, even a McPherson can do. For the enclavation of the iris tissue into the claw, I use a reverse Sinskey hook or a rod. Even if that's not there, Sinskey hook also can do that job, but with a slight manipulations. Now, is this technique very difficult? Not at all. It is a very simple technique with a very minimal learning curve. Coming to the procedure, in a vitrectomized eye, I always prefer to do the side ports first. And the main incision can be either a temporal or a superior section. It can be either a corneal or a scleral section. I always prefer to do a superior corneal section, because in a scleral section, the AC might tend to collapse more than when compared to a corneal section, and also to save the superior conjunctiva if needed for a future trap. Once the IOL is placed, dial it into the position in line with the side ports, and with the help of a reverse Sinskey or a rod, the iris tissue can be tucked into the claw. And note the movement of the direction of the rod. It should be like vertical down and come out. It should not be a vertical up and down movement. So what I have learned from my mistake, especially in a vitrectomized eye, if we do the side ports first before the main incision, the globe is very much stable. In the first video, the main port was done, and later when I have done the side ports, the eyeball was collapsing so much. So in any cases of colobomas or of microphthalmos, so because of the size of the iris claw is slightly less, this can be placed in coloboma cases. And now, what complications should I be dealing? If the technique is right, if the things are done in the right way, the less likely to have any complications. This is my 10 years post-op where the vision was fantastic, it was 6/6. But definitely it is not without any complications. There can be an ovalization of the pupil. I don't say it is a complication. Probably the patient might have a cosmetically unhappy, but visual wise there is no problem. Then there can be a pigment dispersion. Even if we have a pigment dispersion, not to worry, it can be taken care with the topical steroids, or if at all not happening with the topical steroids, one can use a YAG laser to disrupt the pigments. The site of enclavation, there can be a progressive iris atrophy, which can be a risk factor for loss of enclavation. And if there is a loss of enclavation, if only one haptic has lost enclavation, even the anterior segment person, there we can just get it into the AC and refixate it. But if both the enclavations are lost, we have to resort to the vitreoretinal surgeons who are always there to help us out. If things are done well, nothing happens. But if sometimes, if the claw gets fixed in these positions, that definitely causes a visual disturbance. And in such cases, not to worry, we can still disenclave the iris claw and re-enclave it. Disenclaving the iris claw is tricky, but it is not impossible. And the site of the PI is very, very important. As the name suggests, PI is peripheral iridectomy. That means it has to be done in the periphery. That's it. No deviation from it. In this case, my mistake was I have done iridotomy or iridectomy. It is in the mid-periphery position. When I have dilated the patient, the optic edge was caught into the iridectomy site, and it went into a pupillary block glaucoma. So one more, the biggest query what we always have is the uveal tissue is being handled. So is there an increased incidence of developing a CME? Theoretically, yes, but practically I have hardly had a very few cases, about 1 to 2%. But yes, definitely there is a chance of developing an Irwin-Gass syndrome. Probably it might not be just because the claw is hanging onto the iris tissue. There may be other so many reasons, because multiple surgeries also might have been done, one thing, or probably that eye has a propensity to develop a CME. And one more thing is there will be I don't know if the video is playing. There is a pseudophacodonosis. So because of the pseudophacodonosis, what happens is this will be inducing PVD. This PVD will induce HSTs and there can be an RD development. So this is where an SF IOL actually scores over an iris claw IOL. But if an anterior vitrectomy is done properly, the contact between the vitreous and the optic edge is not there, so we are reducing the risk of the development of the PVD. So if the things are done well, things will not go wrong, and we'll have good results with the iris claw. Thank you.
Thank you. That was a good presentation, Dr. Tanvi.
So since everybody's talked about multifocal and EDOF lenses, I think it is wise to see the real-life experience with advanced monofocal for intermediate vision. That's what we are going to talk about. Now, over the last decade, we know with the digitalization that has come up onto us, we need a vision that is good for intermediate, because a lot of these things that you see over here are required for a 40 to 70 centimeter distance. And we need a lens which will give us no dysphotopsias, are not too big a burden as an economical side of things. And we see that trifocal EDOF already do this work, but a lot of us still resort to the monofocal option because it is giving us extremely crisp and it has proven its worth for distance vision. So we wanted to find an economical option which was devoid of any glare, halos, dysphotopsias, and which gave us practical independence for patients. And we know a lot of studies have been done with monofocals using monovision. So we have done this study in our center to look at the subjective and the objective outcomes of patients who were bilaterally implanted with Clarion IOL, which is a monofocal lens, and we targeted them for mini monovision post-op. So this was a study done at our hospital at Lakshmi Eye in Panvel. It was for a duration of 12 months, and we enrolled 90 patients. The primary objective was to see binocular uncorrected intermediate vision. Then we also looked at the binocular uncorrected near vision and the binocular defocus curve, and then we did a CRISQ score. It was very interesting to see for the spectacle dependence all at 1 and 3 months post-op. So we included those patients who had been implanted bilaterally with the Clarion lens. Obviously, the patient had to be more than 18 years, having an age-related cataract. We included only those who had a pre- and post-corneal astigmatism less than 0.75. We excluded all those who had any intraocular surgery done or any additional procedures that were required. And the post-op manifest refraction had to be more than or equal to 0.25 in the, or rather less than or equal to 0.25 in the dominant eye. And if it was more than 0.75 in the non-dominant eye, we excluded. So mainly what was done is that dominant eye was targeted for emetropia and non-dominant was targeted for 0.5. So our results showed almost equal distribution in the male and females. We saw that the residual spherical equivalence satisfied the inclusion criteria, with the dominant eye being close to emetro and the non-dominant eye was less than 0.75, and the astigmatism in both the eyes was less than 0.5. The binocular distance vision acuity, as we expected in a monofocal lens, was very good. It was close to 20 by 20 at 1 and 3 months. The median binocular intermediate vision at 3 months was 0.23 logMAR, which is 20 by 32 or 6 by 9 vision. We saw that the distribution for the study population showed that almost 71% of these patients enjoyed 20 by 32 or better vision at 3 months. And this trend was more popular at 3 months as compared to 1. Interestingly, after we corrected these patients for distance with glasses, their binocular intermediate still remained at around 0.2 logMAR, or almost similar, that is 70% of patients. The binocular uncorrected near visual acuity at 3 months was 20 by 50, that is 0.4 logMAR. And we saw that around 22% of these patients enjoyed 20 by 40 or better vision at 3 months. The defocus curve was quite good. It showed a good distance and intermediate vision, with a curve showing a smooth and wide landing zone. And this curve was slightly better at 3 months, although not statistically significant. We evaluated the CRISQ score and wanted to look for spectacle dependence. And when we asked the patients if almost 51% said they didn't need glass for intermediate vision, and 41% only needed it for occasional use. So that was its astounding 92% of patients who didn't need glasses throughout the day for their intermediate vision. And when we asked if you are able to function comfortably without glasses, 73% of them said yes for all the time. We also analyzed the study population according to different ages, and we found that the mean binocular uncorrected intermediate vision was better as expected in a lower age group, that is in younger patients as compared to the older. But this difference was not statistically significant. However, all of the younger age patients, that is 100% of them, were comfortable without glasses for intermediate, while the older age obviously required it for occasional use. And this difference in the comfort between the age groups for intermediate vision was statistically significant between the two ages. We also looked at the asphericity of the cornea, and we found that the intermediate vision was better in patients having more negative Q value. But I think we need a larger sample size to ascertain a relationship between the two. So to conclude, I would say that since we have all the lenses at our disposal, if you're thinking and wanting to give your patient something more with a monofocal, a bilateral implantation, at least with a Clarion IOL, targeting for mini monovision does give you an excellent distance and good functional intermediate vision. We see that the visual outcome is stable over 3 months. The smooth defocus curve showed that it gives a functional intermediate vision for practical routine. And we found that it may work better in younger patients, and if eyes may have a more negative Q value, it shows better. And there is definitely a reduced spectacle dependence for intermediate as well as near in some patients. Thank you very much.
Thank you, Dr. Sanjeev. Once again, we apologize.